Hello, welcome to part 6 of my series on respiratory therapy for nurses and healthcare workers. I want to talk this time about respiratory assessment. And as a nurse, what we're taught is to do an assessment that is head to toe or by systems. So we would start with neurological and then work our way down. As a respiratory therapist, though, I was taught differently. We use what is called the spoke wheel method. In other words, we start with the lungs always, every single time, and then we move a little bit over to the heart, we move up to neurological, move down to GI and urinary, and then we look at the skin. And to this day, when I walk into a patient's room, because they're my patient that I'm taking care of, or somebody's asked me to look at a patient, I'm always starting with the respiratory rate. That's the very first thing that I want to know. So when I assess a patient, I look for respiratory rate, and then I want to ask myself, why is the patient breathing at the rate that they are breathing? There has to be something going on to make them breathe that way. Now, normal respiratory rate is, for an adult that is at rest, is probably somewhere between about 12 and 18. Some sources say up to 20, some sources say as low as 10. But basically, somewhere in there, 12, 14, 16, 18, I consider to be okay. What's interesting to note, if over 37 years I've noticed, if you take a look at any patient's chart and look at their assessments and look at the vital signs, the most common documented respiratory rate is 16. I do not know why, but 16 just seems to be the most prevalent number. And a side note, I'm not going to be talking about breath sounds. There are many good sources, even on YouTube, on what breath sounds are supposed to sound like, both normal and if you have abnormal, adventitious breath sounds. So I'm not going to talk about that. Okay, but getting back to respiratory rate. So if I walk into the room and somebody's breathing, let's say that they're mildly tachypnic. That means they're breathing at a rate of 24, 26, 28, or even if it's acute tachypnea, 30, 32, 34, or higher. I'm going to ask myself, why are they breathing this fast? There's got to be a reason. And I'm going to list these reasons for you. So number one would be pain and anxiety. Somebody who's in acute pain, they have a lot of anxiety, maybe they just had a procedure that was painful. Maybe they were just told that they've got cancer. Those kind of things could make somebody tachypnic. And here's a good example. I do woodworking as a hobby and I build furniture. And several years back, I cut off most of my left middle finger. I was in my shop and I was cutting a board on a table saw. And the motor makes a very high-pitched sound. And then all of a sudden it went, and it slowed down. And I kind of stepped back because I didn't know what was going on. And that's when I noticed there's blood on my table saw. And I saw blood squirting out of the end of my finger. So, being a good clinician that I am, I grabbed a rag as quick as I could, full of oil and sawdust and debris, and stuck it on there. So I was in pain. A carbide tip blade will not differentiate between oak and maple or bone. It'll cut anything that's in its path, and it did on me. So yeah, I was in pain and I had a lot of anxiety, knowing that I'd have to go in and tell my wife that once again I've cut off a piece of a finger and she's going to have to take me to the hospital. So yeah, I was in pain, I had a lot of anxiety, and I'm sure that I was tachypnic as a result of that. Another reason why somebody could have a high respiratory rate is if they've got too high of a CO2 or too low of oxygen. And how this happens is that we've got chemoreceptors in our body. Prevalently, they're in the carotid arteries and the aortic arch. And those are called carotid bodies and aortic bodies. And what they do, again, try to be as simplified as I can. Basically, they're watching the blood flow by. And as they're watching it, they're counting how much CO2 is there, how much oxygen is there. And we will always breathe based on our CO2 level primarily. Secondarily, what our oxygen level is. So the movement of air into and out of our lungs is actually called ventilation. But we don't talk about ventilatory rate in somebody who's not on a ventilator. We talk about respiratory rate. And predominantly, if the CO2 starts to raise, we're going to breathe faster to compensate for it. If our oxygen level drops, we're going to breathe faster to compensate for that. Besides the chemoreceptors, we also have what are called stretch receptors in our lungs. And what they do is they respond to the stretching effect of taking in a breath. So the body knows, the lungs know that when we have inspired and we reach a certain point, respiration will stop and now we can exhale. Inspiration requires muscular work. Expiration is supposed to be passive. And the reason I say this is because if you've got somebody who has a restrictive lung disease, which is right here, those stretch receptors are not being stimulated because a restriction is a problem with trying to get enough air in. It's a disease process of inspiration. And earlier I said, the example that I can think of is if you take a rope and you wrap it from your waist all the way up to your shoulders as tight as you can, you're not going to be able to take a deep breath. And so instead, you will be breathing rapid and shallow. And that is what happens with restrictive lung diseases. Those would be things like pneumonia, pneumothorax, hemithorax, pleurisy, pneumonitis, those types of things. Those are restrictive lung diseases. Also, we can breathe fast, we can be tachypnic to compensate for a metabolic acidosis. We have to maintain a normal pH range for the body, which is about 7.35 to 7.45. And we have two different systems at play. We've got our respiratory system that controls CO2, which is an acid, and our metabolic system, which controls things like we could have a ketoacidosis for a diabetic. You could have lactic acidosis if you're in anaerobic metabolism, uremic acidosis if you've got kidney failure. That type of an acidosis, the body will attempt to recorrect the pH, and it'll use the respiratory system. It'll make you tachypnic to blow off more CO2 to compensate for another type of acidosis. The last thing to talk about is somebody could have a very high respiratory rate if they have some sort of a neurologic pathology that is taking place. Maybe like a hemorrhagic stroke, they've got a brain tumor, an embolic stroke, those types of things. The next thing I want to talk about then will be the respiratory pattern. Not just the rate, but how are they breathing? There's lots of different respiratory patterns. I'm going to talk about the two that are most common. The first one being Shine-Stokes respirations. And the best way to understand it and to explain it is to actually draw it on a board. So Shine-Stokes respirations starts with a period of apnea. And then after that apnea, the patient is going to start to take breaths, shallow at first and rapid, but then it's going to crescendo into very deep respirations and very rapid. And so it would look like this. They would start to breathe shallow, but then it's going to get deeper and faster and faster and deeper. And then, once that is done, it's going to have a diminuendo effect where it starts to become shallow again. So then it would look like this. So now it's starting to get shallow until they have another apneic period. This pattern is repeated in a cyclic form. Now, Shine-Stokes respirations you will most often see in two types of diseases. The first one is somebody who's in congestive heart failure, and especially if they're in congestive heart failure and they're asleep. And I challenge you, go into a patient's room at night when they're asleep, that they have congestive heart failure, and watch their breathing pattern. And you will see this pattern. And what I've actually done is I've put my hand right on the chest so I can visualize and feel at the same time. And I promise you, you will see this pattern. This type of pattern, Cheyne-Stokes, in somebody who has congestive heart failure is not an issue. You actually expect to see it. It's not telling you that the patient's ultimately going to die real quick. You would expect to see Cheyne-Stokes in congestive heart failure for a whole host of reasons. But it is considered to be normal, and it is okay. But the other type of disease that you're going to see Cheyne-Stokes is in somebody who's had some sort of a neurological insult, maybe a hemorrhagic or embolic stroke, something acute. The problem with Cheyne-Stokes in that type of a setting is that it is a very poor prognostic sign. Generally speaking, what I have noticed is that if somebody has a neurological insult and they are in Cheyne-Stokes respirations, usually they will expire within about 72 hours. Okay, the next pattern that I want to talk about is called Kussmaul's respirations. This is a pattern that is very specific to somebody who is in diabetic ketoacidosis. I worked with a respiratory therapist, and she was a very brittle diabetic, and there were several times that she went into ketoacidosis, and she asked for two things. She asked, number one, to be intubated and ventilated, and number two, she wanted bicarb, as much as we can give her. Of course, we didn't do those. But Kussmaul's respirations is in the face of ketoacidosis, which is a horrible acidosis to be in, and your body is trying to compensate so much in the clearance of CO2 in the face of a metabolic acidosis that you breathe as deep as you can and as rapid as you can. So this is basically what you're going to see. The patient comes in and this is how they're breathing. Now, try that at home and tell me how long do you think you can go before you reach the point of diaphragmatic muscle fatigue. And you're going to start to feel dizzy because you're blowing off CO2. This pattern is life-threatening because if they fatigue, what's going to happen is the CO2 will start to climb, and now they've got a combination of an acute metabolic acidosis along with an acute respiratory acidosis. Okay, so now I want to talk just a little bit briefly about some cardiac assessment. We measure blood pressure, but what is the blood pressure really actually telling us? We have systole, we have diastole. Systolic function, really is showing us the pump activity of the heart. That's what gives us our systolic number. Our diastolic number, though, is really showing us vascular tone. And you have to kind of keep those in mind. And to just, again, be as simplistic as I can, I'm going to explain blood pressure in a little bit different way than maybe you've heard before. So let's just say that this is the vascular system. In other words, it's the chambers of the heart, it's the arteries, the arterioles, the capillary bed, the venules, and the veins, back to the chambers. So this circle represents my entire vascular space. And inside of this vascular space, I have circulating blood volume. So there's volume. Now, if I were to hook up a pressure manometer to my vascular space, it's going to read a pressure because the fluid in the vascular space is putting pressure against the vasculature, against the vessels. And so I hook up a pressure manometer, and it's going to give me a pressure. Let's say it's going to be 120. Okay, so that's good. That's a good pressure, right? And we'll say that because I don't have any vascular disease, we'll just go ahead and pretend that it's 120 over 80. Okay, so with our vascular space, things can change that we have to be cognizant of. And for instance, we could have an expansion of our vascular space. Let's say that our vascular space increases. And if I don't change the circulating volume in now my expanded vascular space, you would expect that the blood pressure is going to drop. Now, in your assessment and when you're caring for your patients, you need to be thinking about this because there are different things that can cause an expansion of the vascular space. And for instance, chemicals, we can give pharmacological agents that are going to cause expansion of the vascular space. So if our patients normally are hypertensive and we get an anti-hypertensive to that patient, you're going to expect that you're going to see a drop in the blood pressure. I would caution you, make sure that they are hypertensive before you give that antihypertensive. Because if their blood pressure is down from what they're used to, well, now what's going to happen is you're expanding that vascular space and their blood pressure is going to bottom out on you. So we know that chemicals, pharmacological agents, can affect the vasculature. But there's something else that oftentimes we don't think about that is very, very important. And again, this is all part of your assessment. So if I walk into the room and the patient's got a fever, they've got a high temp. Maybe I check their temperature and it's 102. Well, they're flushed, they're red. What is that doing to the vascular space? It's expanding it. So in my assessment, I should notice or anticipate that with that fever, they may have a drop in their blood pressure. I'm certainly not going to give them any antihypertensive medication because I don't want to compound the problem. And so, of course, now the fever, the temperature, leads you down another path as to what's causing the fever. They have some sort of inflammatory response, maybe from an infection. Where's the infection? That's going to lead me to my breath sounds. Do they have pneumonia? Maybe we need to get a chest x-ray. How about their urinary system? Are they making very, very little urine? It's very, very concentrated. And now you ask the questions, do you have burning when you urinate? Is it cloudy? Maybe they've got a UTI that's brewing. So when you check the cardiac system, don't forget all of the ramifications of what a blood pressure is really telling you. Thank you very much.